Okay. Okay, recording. So, Assalamualaikum everyone. Very good morning. So, today is episode 2 of our CME for Uitm Cardiology, and today's topic will be under the theme of heart failure, which will be presented by Dr. Shazwan Shahruddin. The topic is iron deficiency in heart failure: the who, why, what, and when. So, over to you, Dr. Shazwan. Keep it to half an hour. Thank you. All right.
Bismillahirrahmanirrahim. Assalamualaikum and very good morning to everyone. I'm Shazwan. Today I'll be presenting on this topic. So basically, most of the talks are relying based on this recently published paper, 2024 February, by the British Heart Foundation. Introduction. Heart failure, iron deficiency in heart failure, there's around 50%, 47 to 68% among all failure patients, regardless of the severity. Reduce mid-range or preserve ejection fraction. And the patient with a more severe heart failure will more likely to have iron deficiency and anemia. So if you want to see at the table, you see that with patient with EF less than 50 or 100, the prevalence of iron deficiency is up to 50 to 60%. And the data that we have on the outcome mostly on heart failure with reduced ejection fraction. So what we know is that those who have iron deficiency in reduced ejection fraction, the mortality and hospitalizations are increased and the quality of life and functional status are reduced. So what we have, and we'll be talking more today, is on giving IV iron, ferrous carboxymaltose, which we know from the previous study and the latest one that it improves. And the current guideline, what do you recommend on it, which is ESC 2023. So a little bit on what it is, the basic stuff back. Ferritin transferrin saturation that we usually do. So what ferritin is, it's an intracellular storage of iron in non-reactive form, whereas it's produced in response to intracellular and iron to the inflammation. Whereas in transferrin saturation, it reflects the iron availability and direct delivery to target tissue. Hepcidin we didn't really measure, or even soluble transferrin receptor, but then it is produced by the liver in response to iron and serum inflammation. So again, in stabilized form, ferritin, it measures stored iron. It's not affected by short-term variation in iron intake. The limitations are that it's affected by inflammatory states. If patient got infection or what can be falsely elevated, whereas transferrin saturation is not affected by the inflammatory state. It measures the transport of iron available for cellular uptake. Serum iron is a direct measurement, but it does not reflect the iron stores. Okay, this image actually tells you that this is the gut mucosa from duodenum, whereby the iron in Fe2 plus is absorbed by the duodenal gut mucosal cell and stored as Fe2 plus. And then with the hepcidin punya effect, hepcidin will increase in the liver. Hepcidin is produced by the liver and will increase its production in the case of inflammations. So what it does is that it reduces the release of the ferrum Fe2 plus. So the Fe3 plus is actually needed for the iron, for the heme production later. Apart from that, not sure.
Nampak muka kau? Oh, amazing. No. Okay, betul. Yeah, okay, great, okay. This is a recording gone wrong. All right. Dismiss. Okay. Can see the slides, ke? You of course lah.
Okay, that's
Saya gunakan. Sorry. Sorry for the glitch. Okay, again, same thing. The androcyte is in the duodenal guard. Fe3 plus is absorbed and stored as Fe2 plus. With the effect of hepcidin, it will affect on the ferroprotein and will modulate the release of Fe2 plus in the bloodstreams. Okay, if not, the Fe2 plus is stored in the macrophage or hepatocytes as Fe2 plus. So based on the WHO anemia, HB is less than 12 gram for women and 13 for men, whereas the definition of iron deficient based on international heart failure guideline, they follow, this is the old one now, but then they follow, most of them follow ferritin less than 100 or ferritin between 100 to 300 with this set of 20. This is what they usually do in all the studies in iron deficient in heart failure. And then WHO said otherwise. They said they define iron deficient as serum ferritin less than 15 microgram, which generally reflects low or absent bone marrow. The gold standard of diagnosing iron deficient is by using bone marrow BMAT, but then we don't usually do that, right? So, however, chronic inflammatory disease like heart failure can increase the ferritin synthesis and also increase hepcidin, which impairs the absorption of dietary iron from the duodenal mucosa. So, in turn, patient can have a low iron for metabolic function and have a normal or raised serum ferritin. Okay, T-site and serum iron may be more useful for so we usually do serum iron and T-site for identifying iron deficiency. So okay, again repetition. So why? So iron is fundamental importance for hemoglobin and myoglobin production, and it's also vital for mitochondrial energy production. So we want to correct it so that it may increase hemoglobin and myoglobin production and improve the metabolic function. That's the reason why we are trying to correct the iron deficient in heart failure. So why also? Because those who, repetition again, incurred poor prognosis among patients with heart failure associated with low peak oxygen consumption, higher ratio of ventilation to carbon dioxide production, higher mortality, and higher risk of hospitalization. How? Depletion of iron store leads to is a result from insufficient nutrition uptake. So it's also a result for impaired absorption or chronic blood loss. So it's important in clinical practice to get a good history, especially dietary history, and then a family history of blood-related disease, or there is a chronic blood loss from the patient, especially those who have heart failure usually had concomitant cardiovascular disease, which are on aspirin. Also, okay. So, treating iron deficiency in heart failure, we found out it improves symptoms, quality of life, and exercise capacity. And then the quality of life improvement was seen within 4 weeks and persisted for almost 5 months. And the benefit observed whether or not patient had anemia. So if you want the data, this is from one of the meta-analysis, 2023, by Menzel Hensel. Okay, they found out that the composite outcome and all-cause mortality favors toward iron. With if you see the data from 2008 up to 2022, the all-cause mortality is favor towards the forest chart is less than 1, which favors on iron. Sorry, what?
Is it significant?
Not.
It's not significant yet. So you guys know how to interpret this chart. So if the lines are too confusing, just go for the diamond. Yeah? So the diamond is an accumulation of all the top line. So you have the diamond is more on the left, but then you look at the p-value. The p-value is less, it's not 0.05 or less. Because we know that iron depletion doesn't confer benefit for mortality. So actually, yes, nampak macam favor, tapi actually no, not significant enough for all the accumulation of the study.
Okay.
And so to mortality, cardiovascular mortality juga.
Okay. In terms of hospitalization for heart failure, yeah,
So the diamond is a bit more on the left.
yeah,
Okay, but then the p-values,
not
the test for overall effect. So what's that? That's what they're banging for lah. Your overall to p equals 0.04. So it's slightly you can argue, but there were some things that they've done for certain studies. So most of the studies that they got for IV iron were done during COVID period. So actually, when you took all the data together, it's 50-50, but then when they did some adjustment, it seems significant. Seems significant. That's what they're banging on. Okay. So it's mainly for hospitalization, right? Based on studies.
so. Between IV versus oral, IV is the preferred therapy. Among the reasons are oral iron supplements are limited. Amount of is absorbed from the gut, its metallic taste, and the high percentage of side effect lah. Most likely, the chronic inflammation from the heart failure will result increase in hepcidin, which later will reduce the gut absorption of the iron.
That's the theory. But what is the more important reason why IV beats oral?
The dosing is
No, there's a study kan that showed that oral iron didn't work for heart failure.
yeah, ada.
Okay, what's the study?
This one iron out. The iron out heart failure.
So the main reason why
Yeah.
we are not using oral iron lah.
Yeah.
Because we have a good study, a robust study that showed that oral iron doesn't work.
Yeah. Okay. This is the iron out study. Is actually the one who said oral iron doesn't work lah. Okay. And then that is what I want to highlight from this. Okay. This is among the latest affirmed acute AHF, Ironman and heart fit study. Latest is 2023 lah. All look into the usage of IV iron, and they recruited all patients with heart failure with reduced ejection fraction or mid-range. For affirmed acute heart failure, they want to see the primary endpoint was actually to see whether total hospitalization and CV deaths. But then they found out the total heart failure hospitalization there is positive, but then the CV death is not significant in giving IV iron. But then for the Ironman, it is a positive result. The primary endpoint shows that there is a reduction in recurrent heart failure hospitalization and CV death.
But it's a composite, composite, which is combined still. So when you broke it down to either hospitalization or CV death, it still didn't favor CV death. Even by hospitalization, okay? So it's still the same actually. So there is no mortality benefit for IV iron, both FCM and Monofil.
Okay. Because of the reduced hospitalization, they reduce the
like what Dr. Ahmed, it's driven by, so very important. Kadang-kadang what studies do is you'll combine all the endpoints to make it really, really macam cantik, evaluate. But when you break it down, you need to understand what drives that result. And the main driver for the result is purely hospitalization. And so very important to highlight because actually other sub analysis that showed that it really is mainly hospitalization. It doesn't help with dying, basically.
Okay, this is the thing I don't want to do. Okay, the implication of the clinical practice is that patient with heart failure reduced or mildly reduced should have their iron status checked periodically.
How periodic is periodic?
From my reading, it's every 6 months.
Yeah. 6 months. Yeah. Practical 6 months, I don't know. But 6 months is what I will try to remind myself. Okay.
There is a little implication that patient with TSAT more than 20 would benefit from IV iron, presumably because of not iron deficient. They put those who have more than 20% in fact have a negative implication if given IV iron. they took the data from the IPD 2023. But then those who have mild or moderate anemia, they will benefit from IV iron. So what we have, this is from our 2019 pharmacist punya iron deficient. What we have here is monofer, and then we have cosmofer kat sini lah. Monofer, the dosing we use is 20 mg per kg. Later I'll show the table. It's easier, it has been calculated already lah. The cost is roughly around 340 ringgit for 500 milligram lah.
How much is it?
338, 10 cent. 340 for 500 mg.
So the 20 milligram per kilogram tapi max out at 500. Kalau kilogram dia besar kan, patient kan, itu max out at 500 lah. So
We favors more towards the
ada
new.
binofer juga.
Binofer.
Kita ada binofer juga.
Oh.
We also have binofer.
But we're using monofer most of
We need
the.
evidence is for monofer lah.
Yeah, IV there is so maltose lah. Okay, this is the same thing actually. Okay, this is quite a good chart lah. So they divide into step 1, step 2, step 3. First you check periodically, 3 to 6 months, the iron status. Look, those who have HFrEF or heart failure with mid-range EF, or heart failure admission or clinic visit. Those who have a T-sat less than 20% and ferritin less than 400, you proceed to step 2 lah. You want to calculate the dose of IV iron, and it benefits mostly those who have HB less than 12 for women and men with HB less than 13. So we calculate, what we use, the monofer is FDI lah, 20 mg per kg. Monofer is FDI, so we give for every 4 weeks to 4 months, and then we recheck back again, remonitor and redose every 4 to 4 months after the first dose. And then the key point is that the dosing generally needed only 1 to 2 times per year lah. Itu yang saya faham lah. Alright. So calculation, this is slightly easier lah sebab dah ada table. This is from the PPUKM formulary apps. So kalau HB less than 10, body weight 50 to 70, roughly around 1500 milligram. Kalau 50 to 70, HB more than 10, around 1 gram lah. For those between 70 kilogram. And then if patient needed only less than only 500 milligram, you can give them as a bolus injection, undiluted, or you can dilute with 20 cc normal saline. Lebih kurang 2 to 3 minutes je boleh bagilah bolus. But then those who need roughly around 1 gram, they should be given more than 15 minutes. But then those who need more than 1 gram, 30 minutes or more lah, and diluted in 100 cc normal saline. Dah saya kira senang.
Kita ada wakil ICL. So we are doing our IVI dekat ICL kan. So kita dah data I'll speak to Kak Wendy lah. Because we are trying to decide the dosing untuk ni. We will decide whether we want to use the UKM one or we want to just follow the iron suite yang they showed from Beverly Hospital dekat Singapore kan. So we're deciding each one or the other. Nanti we will propose to you guys. Tengok macam mana.
Okay.
Which one is more easy to use? This one macam for Limato actually. That one built for Regen or IVI. That one seems a bit more cantik lah. So memang we'll see. Try to get that
Pun memang for outpatient.
outpatient, correct? We wanted to get outpatient punya dosing lah sedang patient balik.
So from what I read, also there's no test dose required, but then patient need to be observed at least 30 minutes following the infusion. Yeah, after.
So the other one has a test dose, macam bangun meal, and then do like 15 to 20 minutes, and then do reaction, and then come full. So I thought increasing test dose, Kak Wendy also is in favor of test dose juga. We'll see.
Okay, in terms of safety, they have a good safety profile, especially the monofer lah, the newer one. Patients should be educated on the infusion process, And then it's not IgE-mediated hypersensitivity, but then likely complement activation related to the pseudo-allergy. They call it CAPRA, due to the labile free iron. This is a table one. Alright, symptoms pruritus, urticaria, flushing, chest tightness, joint pain. Okay. Okay. Just want to highlight also it's extremely rare in terms of reaction and should not be a barrier to the use. Something to worth reading on. I think they also some of them highlight on the treatment emergent hypophosphatemia, which is they are looking into it following IV iron. So in terms of pregnancy, avoided. Yeah, not okay. So key take-home message, it's an important comorbidity and is prevalent among patients with heart failure, often neglected. Treatment leads to reduced hospitalization and all-cause mortality. Okay, and T-set less than 20% more likely to benefit with IV iron. And the ESC class 1C recommendation, screening patient with heart failure for iron deficient, and 2023 class 1A, if iron deficient, to reduce symptoms and improve quality of life patient have ref and mid-range EF. So we should not forget also, patient need to be screened also from gastro juga lah for scope, because this study actually noted that the prevalence of GI malignancy in iron deficient heart failure lah, because they recruited around, this is a retrospective study lah. Dekat Belgium, they looked at those around 1,200 patients with iron deficient, whether anemic or not. There are roughly around higher prevalence of malignancy compared to no iron deficient. So just want to highlight that lah. So but then I didn't mention much about preserved ejection fraction. They are looking into it. Doesn't.
So stick to
Alright.
so far.
Okay, I didn't cover about the iron deficient heart failure and reduced kidney function lah. That's all.
So any questions from the floor? So we are starting. We already had one lah. We were supposed to have the second one, but the second one failed on us for some reason. Tapi there are patients out there yang we will routinely do iron as part of our workup in heart failure clinic. The thing is, if you're going to screen, we rather act on it lah. Don't just screen je lah kan. So if you see the criteria is met, then discuss with your patient about the possibility of starting them with IV iron infusion lah. Do you have to wait until the GDMT is completely maximally all uptitrated? Not necessarily actually. Okay, sometimes you don't have to wait until that point. Do you have to investigate for things? Yes, you still have to, as what you highlighted earlier. But you can see, but it's all based on history. The patient should have suggestive history. The other patient yang kita ada iron deficient, turns out, thank God we didn't. Thank God he saw a rescue physician prior. He had TB juga. So there's a lot of things that can overlap. So your history taking is still very important. Okay, but in the absence of anything else that's suggested, then consider treating the iron deficiency to help in the heart failure, especially if the patient has come into hospital multiple times.
So far none of the GDMT increases iron.
Yes, SGLT2 reduces.
SGLT2.
Tapi in a good way. So SGLT2 might reduce your iron because it uses it efficiently for the heart. So that's a good kind of reduction. But others don't understand it.
So that's why you start by having once the GDMT is optimized.
Correct. Don't have to wait. And should we check iron in the ward? Actually boleh, because in the studies, all the IV iron studies, some were done outpatient, some were actually done inpatient, some were done closer to discharge, some were done midway through when you look at their timeline of testing iron.
Because that's why the guidelines does not rely on parity.
Correct.
Because kalau dia ada admission, sometimes the parity might increase because of inflammation. So now they're going away from the parity. They just want to see what the T-set is, and then therefore you can.
T-set won't be affected in patient outpatient, so should be fine. The other thing is you mentioned quite rightly, safety profile. Actually, Monofer, the new agents are actually very safe. We've done the study, post-hoc analysis study for the Ironman here, and actually hardly any adverse events. Definitely no serious adverse events. So don't worry so much, but what we are going to adopt as a policy for UITM, we'll discuss later. We still might want to give a test dose.
So then what do you want to do if, let's say, you have given the IV? So how are you, what's your management, what do you call it, follow up?
Follow up.
So that means the ASC has clearly said that you screen.
4 weeks
Let's
to
say
4
now it's
months,
found,
you repeat again.
Found, and then you have given the dose.
Yeah.
Okay, so I find that it's a bit difficult because the trials gave the dose to the body weight. But because sometimes if you give the dose to the body weight, they might need 2 vials.
600.
So that would be too expensive.
Yeah.
So far, I think I'm thinking the best.
500.
Satu vial. If just the 500, we assume that it will be adequate. So maybe that's worthwhile to do a trial because we are just giving this one vial, which is not what is recommended. I think we do not know how whether they, that means in more economically challenged countries, maybe 1 vial is sufficient. So we don't actually know. Tapi then what is the mechanism for us to see the response?
So usually from this, we recheck back the iron status 4 weeks to 4.
Which one do you check on the 4 parameters? Which one is more reliable?
We use T-set dengan iron juga lah.
Okay, but whatever, what is
How much the increment, right?
So you don't know actually, it's not for you to answer today, you don't know. But
I try to tengok pun tak jumpa. Nobody commit on that.
So kan dia nak no upper limit. The old one used to say 500 milligrams sahaja lah, but it's true. We are actually underdosing them if we are on the heavier side, especially orang putih kan. So far on our side, it tend to be just like 500. But we never know, we'll get a slightly chunkier patient after that needs it.
Because they response from money, it's just their environment. Tapi whether their response to macam mana kan? That's it. Whether you have, we know that the lower the T-set, also they will be better kan? So that means if you have somebody with T-set 70, and somebody with a T-set of 12, something like that. I think the data shows that T-set of 12 will feel better.
Right.
Tapi if you, let's say 4 weeks later, the T-set has just gone up to 8.
Did you give again? Yes.
Or what is it that, or if the patient says I'm much better.
So kalau ikut buku dia say
redose again. Yeah, redose again.
But a lot of gaps on our side. Anyways, we're building up the experience. So guys, kalau ada patient yang think is iron deficient as per ni, and you have ruled out everything else, let us know lah, and kita boleh try to facilitate. We are doing it in the recovery. Kak Wendy, Hafiz has helped set up a shop, so to speak. Okay, hopefully we'll get more.
Any restriction if the patient just recovered from the acute decompensated heart failure?
Oh, actually, there is a data simpan ni. Whether you give now, you give within 6 months or as outpatient, it's actually all favors towards the usage of tak kisah lah. Yeah.
Because you're not going to push the amount dulu you give them with the dextran, so you kasih banyak of my weight. Whereas now you're not giving, so you're not afraid that you're going to push.
This is the post subgroup analysis from the Ironman trial.
Kalau kau rasa kau nak make engagement, and by all means, the patient is ready, want to datang balik HM semua, you feel it's appropriate, but make sure you know what you're monitoring after that. Alright, should we move on? Stop recording. Dan kami kan. Aku nak dengar dua present je.
Tolong present dulu.